pretty busy, and a noon meeting was our goal. I also know that means that you're eating and working simultaneously. So we will continue on, but know that I'm just thrilled that you're here. As you all are meeting each other again, I would also like to say, remember, you can review the chat at all times. You can make it happen on the right-hand side, presentation, who's here, and chat. It's all synchronous and a little overwhelming sometimes, but let's proceed. Next slide, Ann. So, Ann and I talked about this slide today, and I'm just going to say a snippet. I think that we all have established that we're all passionate folks who are involved in maternal health in Kansas. In fact, I would say the next piece of that is the engagement of this group and many tiers of folks across Kansas to improve the lives of moms and babies. And I would extend that to families in Kansas, has been alive and active. Our collective intention is to make Kansas the best place to be a mother. And today we will start the next step towards that goal. Next. I'm going to spend just a few minutes talking about what I'm calling rapid response, what are essentially your hot topics going on in maternal health in Kansas. When I took the job of maternal QI coordinator, I took it very seriously that not only are we working on a global perspective of improving maternal health, but we're also becoming active participants in each other's forward progress. And by that, I mean, not only are we talking about things that we're noticing on previous data, as the team today is going to talk about, but we need to be actively engaged in current topics. I don't want that to be lost. And so certainly the issues that I'll talk about right now are things that you're probably seeing come through your inbox, but I want to have it all in one place, make it easy for you all to access. And again, hopefully we can have rapid change and rapid response to the needs of maternal health care in Kansas. Most of you received an email or hopefully saw the email that came through on the public health sector side, KDHE specifically, on the joint recommendations for syphilis screening. This is not a new topic. We knew that there was an increase in syphilis and congenital syphilis I think that conversation started over a year ago. But the recommendations from KDHE, which are in collaboration with multiple major organizations, including ACOG, ACNM, A1, et cetera, American Academy of Pediatrics, are very specific about recommendations for screening and repeat screening, and certainly as a goal to prevent congenital syphilis. This link and more specific information about that, including 4 very, very good resources for you all to have rapid access to, are in your handout. Next. COVID. So we're still talking because it's still important. And in fact, I would say to you, it's more important this month than it was last month, if that's even possible. Hospitalizations, positives, conversation, and immunization are next up on this topic. This slide speaks to, and the picture is of 2 updated resources that are available to you also on that handout. They're also on the KPQC website and will soon be on the KDHE COVID specific website as well. This slide is a picture of the antepartum algorithm that we talked about last month that Dr. Malik updated. There's also a postpartum algorithm now that's updated and also, again, on the handouts, on the websites, et cetera. Our goal here, guys, is that you have, again, updated rapid access to COVID-related treatment, referral, screenings, et cetera, with embedded resources that are important. Next. Immunization. I feel like I'm watching Santa Claus come to town with the immunization conversation, and it left the building, and now here we go. I know that those of you that are in both hospital practice, at the bedside, certainly in public health, academia, all of us are facing the questions from our patients, from our colleagues, probably within ourselves about immunization for COVID. Maternal Fetal Medicine Association just came out with a very strong statement supporting COVID immunization in pregnant women, certainly follow through with postpartum, and we have provided that information to you as well. I plan to follow that up with rapid fire communication to you all as we get more, to reassure patients, to talk amongst ourselves in an educated manner about how this immunization plan rolls out. but please know that we will give you everything we have as quickly as we have it. But you need to hear the conversation from maternal fetal medicine that came in and support. Next. Medicaid eligibility, we followed this up from our last learning forum. Remember, the continuation of eligibility is what's happening related to COVID, which has been a wonderful, wonderful example of what the state of Kansas is capable of. We're seeing patients fall off of Medicaid eligibility in Kansas, which is allowing access to care, continuation of services, substance abuse, behavioral health, et cetera, et cetera, et cetera. All the things that we're talking about with maternal health improvement continue on because of COVID related policy adjustment. So again, those resources are available to you. We want to make sure that if you have any questions, you contact us so we can help guide your practice and your conversations with patients the right direction. Next. And then a pretty amazing thing happened nearly 2 weeks ago, and that's that the Surgeon General decided to jump on the bandwagon. And I don't mean bandwagon, I mean the most wonderful forward progress that we're all interested in. Health and Human Services produced a phenomenal comprehensive maternal action plan that is really in line with what is needed in our country. And furthermore, Kansas, we are on the right track. And so again, you'll be provided this resource. I beg you to look at the summary report, which talks about what to do next, and make sure that what you're doing in your practice, what you're saying to patients at the bedside, what you're teaching, how you're communicating in the public health sector is all in line with where we're going next to improve mom's health. That moment and watching the Surgeon General along with his entire team of folks roll that maternal action plan out just made me so thankful that Kansas is aligned and ready to take our own action and to follow suit. Next. As we roll into the conversation of today and our esteemed colleagues that are with us to walk through this, I want to remind you about why we're here. The Fourth Trimester Initiative is focused on the idea of a cutting-edge approach to the care that we provide women in our state from the moment of delivery through the first year after birth. Our goal is to engage and empower patients, providers, community to intentionally improve health outcomes. So what our guests today are going to dive deep into is the conversation of the data that you see sprinkled in front of you right now. This is 2019 data. And again, these guys are going to provide lots of in-depth analysis, but there's your numbers from last year to think about. And remember, stillbirths are included in our conversation about maternal health. Do not forget that, please. Of course, maternal deaths, though the numbers are small, the numbers are too big. Next. 8 keys to success. Again, we are focused on conversation, engagement, and moving forward on all of those levels that you see in front of you. Next, Anne. And then the moment we've all been waiting for. We have a collective team here to be with us today. Greg Crawford, we'll call him the team leader. I called on Greg nearly, goodness gracious, 8 or 9 years ago and said, something's wrong in our county. We need your help. And Greg came with his team and helped us dissect the data at that time to help us establish a plan of action. And guess what? Now he's going to do it for us again, except for he's going to do it for our state. So without further ado, I would like to introduce Greg Crawford and his team. Certainly, I hope that he will introduce each of them as they go, but I don't want to take any more time. Greg, thank you so much for joining us today.
Thank you very much. Just wanted to share a little bit of how we're looking at the data and what we will be particularly doing. I'm going to go ahead and share my screen.
Hey, Greg, I
Yep.
messed up, and that's Anne reminding me that I messed up.
Okay.
I need us to take the pre-poll. I get so excited about you, I forget the poll, Greg. I forgot the poll. So Anne, let's put that. So we want to make sure we know where everybody's starting. This is our temperature check prior to the knowledge improvement that our goal is today. So she's going to put up a poll, and we'd like for all of our participants to jump in. Anne, I'll take it from there.
Yeah, can you see it there? I've pulled it up. You cannot see it?
Nope.
Can you see it now?
All I'm seeing is our beautiful pictures at noon on Tuesday.
Can you?
There it is.
There we are.
Great
Thank
job. All right, everybody, jump in on that learning forum poll for us, please.
Remember that our goal today is that you'll be able to prioritize 2 or 3 maternal health indicators that require your community's action. So we're asking, do you have everything you need in order to be able to do that assignment? And looks like about 60% of you have voted so far. So if everybody would jump in and answer the poll, we'll get started here in just a second. About 70% of you have answered. Terrific. Thank you so much for taking part in that. I will show the results with you now, and I will also show them to Greg Crawford so that you know that nearly half, they don't know where to find local sources of county-specific maternal health outcome data, and nearly half know some of where to find it. So that leaves you wide open to let everybody know all that they need to know about accessing sources of county-specific maternal health outcome data. And with that, I'm going to close this poll and allow you to share. Thank you.
Okay, so I think everybody, yep, my screen is up here. So again, we want to talk a little, mostly about where things are at, what is there, maybe do some simple comparisons, but not so much the specifics of any given particular area or any particular indicator. There are a lot of different indicators, and we'll get into some of that. When we look at monitoring maternal mortality, of course, the first thing people think of is vital statistics, and that's been the data set that's been around the longest. Really was never started as a surveillance system, but it has become that. It is, our area in our bureau is, providing some general data analysis and reporting, supporting the other KDHE bureaus on partnerships and data, looking at some specialized areas like PRAMs and syndromic surveillance, which we'll talk a little bit about, and then supporting epidemiologic analysis of the data. So this is something that's improved immensely in my time with the agency. We now have over 25 epidemiologists that are working and embedded in many of the programs within KDHE. So our data resources kind of are vast, and this is only a partial list, but birth, death, and stillbirth showing up. Again, that standard certificate information that we've had for decades. Syndromic surveillance, which those of you who are working at hospitals, you may or may not be aware of. It is essentially your emergency department data presented to KDHE within days, minutes, hours, depending on how your feed stream works. We also acquire the hospital inpatient data and ED data, which is the uniform billing data through the Kansas Hospital Association. And 2 areas that we're all particularly proud of, which is the PRAMS data, something that, for 20 plus years, we've been trying to get that program started. We got it started at about 5 years ago. We're actually on our 2nd round of grants. Hopefully we'll get word from CDC on that. The other parts that are out there are really important because I think they kind of complement what we can gather on those data sources, things like birth defects, family health data. There's a host of data that the Bureau of Family Health maintains, and then behavior risk factor surveillance survey. So you have the very focused survey data from PRAMS, and then you have some general community health data in BRFSS. So all of that contributes to what can be available. In vital statistics, we're updating that certificate every 10 years or so. We last updated it in Kansas in 2005. Some fields are not as well utilized. This certificate was designed at the beginning of the 2000s. Combination of physicians and public health officials coming up with the fields they thought would be captured on a regular basis. Contains perhaps some maternal morbidity measures, but only those that would be available at birth. And hence, it does have some limits. But the reports and the data serve as foundational information for additional study, research, and a progress reporting for the high-level tracking. I cannot tell you how urgently people chase us down for what's the latest infant mortality count. And our reporting goes back into the late 1940s. The certificate looks vastly different from back then. Oops. The big product that we produce, and it's available for downloading, is the annual summary of vital statistics. Literally every particular table that we try to come up with, and I have the full list of those tables that are in the background there of the image. These are specific county level tables of particular birth outcome measures that are in the report, and they'll be in the cumulative slides at the end. So it includes a number of key outcome items, some limited social determinants. You're going to see things like occupation and industry, which is not utilized very much, the status of education, things like that. It's somewhat limited. And then, of course, we track WIC status on the birth certificate and whether the pay source for the delivery. So not much in the way of social determinants, but some. So we have at least 19 tables that are county specific, with the remainder being state level statistics that we want to monitor. So can we do better? Certainly we can. This is just a slide that we pulled. We did a comparison of the vital statistics data for gestational diabetes, induction, hypertension, and you can see that on the scale of sensitivity and positive predictive value, that the hospital data tended to be closer to what was in the medical records than what was in the birth certificate. So somewhere along the way, when that birth certificate information is being either captured or recorded on the certificate, it's not as complete as what the billing data is. So there is then, and has been, a lot of interest in trying to pursue, insights that we can gain from the hospital discharge status of those particular cases. Again, completeness of the certificate is an issue. This is just a quick list of the fields that we dropped along the way, simply because we know they're either not accurately reported, or other studies like the one that we linked birth and hospital data to the medical record just didn't produce sufficient information and insight. Come on, where'd my cursor go? There we are. Okay, so so that kind of, let me make sure I've not jumped over anything. So that kind of wraps up one principal approach to sharing information. The other one is one of our two query tools. We have Kansas Health Matters and Kansas Information for Communities. What makes Kansas Health Matters unique is it's a partnership of health organizations. So the Hospital Association, Kansas Health Institute are partners in it. It plays a strong role in hospitals doing community health assessment, community health improvements, and also local health departments are able to do that. And it provides some longitudinal information which can be beneficial to health assessment. Maintains, we have about 200 indicators, but they're largely higher level indicators. So it's a tool that's perhaps best for community consumption. But we'll show you a sample here of some of the key indicators. So we have identified about 20 key indicators. While there's 200 indicators, when we first rolled everything out, health departments and hospitals said, whoa, that's too many indicators. And so we identified a brief list to give everybody something a little shorter to manage. But overall, there is a lot more. I am having trouble. There we go. I guess I'll just click. So there is a brief summary of the dashboards that are there. You know, we do things by zip code, cities, counties, public health preparedness regions, as well as at the state level. We talked when we were putting the presentation together to kind of share a little bit of what's available. And these are all county level statistics that we've pulled together. And it's more to just give you a sample of, there we are, of just what the depth of material is. So you'll see, you know, average WIC participation, staffed bed ratios. And then if we scroll down just a shade, we should be able to get into the maternal health areas and then see, well, we have infections and infectious diseases. And then we have the maternal, fetal, and infant health. So there's, you know, a number of other indicators that were not listed as part of the key indicators. So this then can be done for each individual county. This is the example that Wyandotte County is probably very familiar with. They were an early adopter of a lot of this comparative information and modeled their own information on that. I'm going to click out of here. By the same token, we can produce data for other counties, same information. The challenge is when we present data in this particular model is that it is based on making sure we have enough events to cover all of the activities and provide no numbers that are too small. So we have to suppress counts, and that means that some of those indicators are not available for the smaller county. Geary County isn't too much of an issue because they're relatively larger, but as we get into the Brown County data, the number of indicators that they see changes quite drastically. But I'm going to do a quick comparison here between the three counties, and you can see, again, just a small subset of all the measures that we produced. And this is actually a custom report where you can go in and decide, this is what we want to see. This is the kind of information that when you're looking to go to a community group or some general presentation to kind of set the foundation, this custom report then gives you that ability. So in this particular case, we're seeing those maternal, fetal, and infant health indicators. You've selected your 3 counties. It might be that you would look at, say, an adjacent county. So if I was out in Southwest Kansas, I might do Finney, Ford, and Seward counties. Here, we've just selected for purposes of illustration. Again, you can see things like, here's the state's value by comparison. The state's value is compared to the US. We do a comparison to the prior value. We try and track a trend. And then we talk about the Healthy People 2020 target. And that soon will be updated to the Healthy People 2030. So you'll be able to then look at birth rates, do the comparisons. You can see the birth rate in Wyandotte County is, you know, higher than the state's rate, or what would be the average of all the counties. So that again is something that it's great for a presentation. One of the complaints that we've had over the years is it doesn't print to paper really nicely, but it will do it a great PowerPoint or slide presentation approach so that you can share that in a meeting. So that's one of the principal ways that we kind of share that at a community level. The other query tool is Kansas Information for Communities. It's all Kansas residents data, the birth data, 1995 to present. It's limited to what's on the certificate. So this is largely going to be the same information that you would see on any of our annual summary tables that we have posted. It also includes hospital data, 1995 to present, again, the high level categories, and some billing data, again, something that would be available in that hospital discharge data set. So this is the layout of our 3 counties. Again, this is a very high level approach. I'm going to take and do the same thing. Again, click it and then launch it. And we'll see here, this is all of the particular indicators plus all of the individual breakouts. So if we're looking at all births, you'll see single, twin, triplet, or higher. So you have all of these measures with all of their categorical results. And then you can begin to see how those counts compare. It also, if I can verify at some point that it works, you should be able to produce percentage rates. If you've ever worked with any of our birth statistics, you'll see that most of the birth certificate statistics are reported as a percentage as opposed to a population-based rate. And that's because you're basically, your calculation is the number of events that have that particular response, say care started in the first trimester, and that's the numerator. Your denominator is going to be the total number of births minus the number of births for which you couldn't calculate prenatal care starting in the first trimester. And yes, we do get birth certificates where it's not possible to calculate that because of information that was not included. So, oops, my bad. Let me get that out there. And so, KIC also includes a module for pregnancy statistics. This is, again, a combination of live births, stillbirths, and abortion outcomes. You can select the particular pregnancy outcome that you're interested in or group all 3 together. Again, it's very limited in what it can do because we don't have a lot of demographic additional detail for abortion data that we might have for birth and stillbirth. But you can at least look at marital status, education, race, and age group. It's available from 1995 to present. It does do population-based rates. So this would give you an ability to do birth rates and calculate things that way. Hospital discharge and emergency department data. So this, for a long time, we've had hospital discharge. Here about 5 years plus back, we were able to work with Hospital Association and obtain their emergency department data. And they were comfortable enough that enough hospitals were submitting it so that we were able to see some things and have it be closely representative of the entire state. So what it does is if you've not seen a hospital billing record, it has a primary diagnosis code and up to 65 secondary diagnosis codes. And whoever does all the coding, they mark it all down. And it's really robust in that particular sense. It's got massive detail, lots of code values, a variety of maternal and infant health codes that are in there. And there's some simple breakouts that this will do. This is one of these data sets where if you get into looking at what we've got on KIC, you'll probably come back later on and say, Greg, can you drill down even deeper? And I would probably say, yeah, that's probably a good idea. So we use the information from the primary diagnosis codes. And so the 65 secondary diagnosis codes are still in the data set waiting to be queried. And so that's where we're going to want to try and enable you to have some analysis of this. Many of the hospitals, if you've got, a good data analyst or researcher, you may have access to somebody that's been able to calculate some of these same things. There's HEDIS indicators, and that same analyst may do other indicators that the hospital chooses. But We have a lot of particular insight. What we're beginning to see, about 1.5% of the records arriving now are showing up with social determinants of health. And so those do show up on birth records. I'm hopeful that that will grow in both quantity and diversity of the number of hospitals that will actually submit. And it does capture information that we do not solicit for on the birth certificate. Obviously, a birth certificate had to have a certain amount of finite information. That's one of the issues that the folks at CDC are looking to rectify in the future and begin to look at a way that we might be able to electronically connect to the EHR system for that birth record and then tie that into the civil registration record so that public health can have access to all of the characteristics of that particular birth rather than just the limited fields we collect. So an example of what our KIC hospital comparison looks like, if I can get it to work today, these are the two indicators that at this very high level of evaluation, complications of pregnancy, childbirth, and that with a breakout so that you can begin to kind of look at some of this. The challenge with all of this is that without some additional filtering, we cannot always tell you that that is associated with the birth or a birth event, or that it was, let's say, between pregnancies or before delivery. So that's again where we would want to look at digging deeper into this particular data set for health, for hospital discharge and emergency department data. At this point, we were going to talk about syndromic surveillance. We still don't have any word yet on Gabe connecting in. Do we know, Anne? Because I will jump in and do her part.
Yeah, I'm checking, just a moment.
Okay.
I'm sorry, I don't see that she's in the room.
Okay. Well, we've all been kind of stretched into additional areas related to something like COVID. So what we did talk about was we were looking for some particular measures that might be of interest to this audience from our syndromic surveillance. So again, a little bit of background that Gabe had prepared. We're getting almost 96% of the ED visits within 24 to 48 hours. And then as the records are updated within the hospital, their EHR systems are tying in. Our data is submitted through CDC, where they maintain the syndromic surveillance database for us, and then we're able to analyze that data. The neat thing is, and this will probably generate a lot of questions afterwards, is that we can give hospitals access back to the data to see the value added parts and pieces that are included in the syndromic surveillance data. So it monitors these health trends in near real time. We capture chief complaint, triage notes, discharge diagnosis. Probably doesn't have exactly the same number of codes as the billing data does, but that's fine. It captures only the emergency department data, so this would be different than the inpatient data, which is where most of our births are captured. Once the record or once the individual is treated in the emergency department, if they're released, that's the end. But if they're admitted to inpatient status, then the data collection on the ED portion of the record ceases. One of the deficiencies there, again, when this was designed back in the late 1990s, they were thinking of just simply seeing emergency department data. Now, practically every public health program has an interest in looking at emergency department data. So we're able to do some very unique queries of free text and get much more better data on situational awareness and variable data quality that really is important as we look at what the data is trying to tell us. One of the things that we were looking at was pregnancy loss that resulted in women going to an emergency department. So I asked Gabe to put together a small query. So, you know, during the last month, we had about 90 visits by pregnant women with COVID-19 that were seen in the ED, an increase of about from 30 visits in October. So we're not exactly sure yet, and this didn't go into the larger detail of what those particular issues were, but they had COVID. They had obviously some complications that required issues to be addressed in the emergency department. One of the other questions that we were thinking is, and Tara has been doing education on me. It's been enlightening. So we talked about pregnancy mental health, and again, during COVID, all of this is really, really critical. And what we're seeing is that there are women who, in this particular graph, we were looking at women who were pregnant or who were postpartum. And as you can see, this is state level data that this is showing up. This would be something that, you know, any public health department would be able to deduce, monitor, partner with a hospital, or the hospital could be working and evaluating their own data to look at some of those issues so that, you know, public health and hospitals could partner on how to approach these particular mental health issues. So the trends that we could look at, pregnancy and pregnancy loss, we've developed that particular query, the ability to determine that ED usage trend in near real time. So we're able to access last week's data. All of these are really helpful areas. We can produce some geographic analysis, comorbidities, and again, we can look at the reason for pregnant women visiting the ED, and you know, when during the year, whether it's more often at different times of the year. So I'm not probably doing justice to what everything Gabe was going to share, but there's a little bit of information on Gabe's connection. With hospitals and health departments, all we say is you just need to sign a brief data use agreement, and then we can work with that individual to how they can create the dashboard. We've worked with Wichita State to develop a user manual, and a video tutorial is being developed. And again, it's one of our goals to really get, you know, somebody who has some research interest at hospitals to join. They can at least evaluate their particular data and see how that can benefit or supplement really what they're able to do with their own in-house systems. And at this point, I will turn it over to Brandy, and she'll tell me when to click on the slides, and we'll tell you a little bit about PRAMS and its progress.
Thanks, Greg. Hi, I'm Brandy Markert. I'm the epidemiologist with the Kansas Pregnancy Risk Assessment Monitoring System, or PRAMS. Next slide, please. So PRAMS is a population-based survey of women with a recent live birth, and our goal is to reduce adverse birth outcomes like low birth weight and infant mortality by gathering data on maternal attitudes, health, and experiences before, during, and shortly after the pregnancy. So PRAMS was developed by the CDC back in the 1980s, but as Greg mentioned earlier, Kansas started data collection for PRAMS back in 2017, so it's pretty new to Kansas. So basically how it works is that each month we sample women from Kansas's birth certificate files. So it's women who gave birth 2 to 3 months ago. And when we're sampling births, we oversample low birth weight births compared to normal birth weight births. And so after we sample these women, we invite them to complete the questionnaire, and they can complete the questionnaire by mail or by phone. So once we've collected data on an entire year of births, we send that data to the CDC to be weighted, And the weighting process basically makes the data representative of Kansas women with a live birth in the state during that year. So it adjusts for our sampling design, it adjusts for non-response and non-coverage to make the data representative. So here are some of the topics in our current questionnaire. You can see that there are quite a few, and they're very wide ranging. So for instance, we ask about healthcare visits. So we ask if the mother went for a healthcare visit in the year before the pregnancy, you know, what kind of visit it was and what they talked about during that visit. We ask about prenatal care visits. So when the mother first started going for prenatal care you know, what kept her from going to her prenatal care visits as early as she wanted, and the different topics that they asked about during her prenatal care visits, as well as we ask about the postpartum checkup for the mother and the well child visit. We also ask about health insurance status before, during, and after the pregnancy. And we ask about health conditions like depression, anxiety, hypertension, and diabetes. We also ask about things like vaccination, the infant sleep habits, the mother's access to basic needs like housing and transportation, as well as social support, just a variety of risk factors and protective factors and potential outcomes from the pregnancy. And at the bottom of this screen, you'll see some green boxes, and those are supplemental topics that we've recently added to the questionnaire. So those include topics like disability, use of opioid drugs, and workplace leave after the infant was born. Next slide, please. So here are some of the data points that I pulled. This is from our 2018 data, and I haven't provided like a lot of breakouts by race and ethnicity or anything like that, just for the sake of time. But here I've just provided a few statistics just to show you some of the information that PRAMs can provide, and it really just scratches the surface of the types of data that we can get from PRAMs. So in terms of mental health, we found that around 15% of women with a recent live birth were indicated as having postpartum depressive symptoms. And that means that they were either experiencing feeling down or depressed after the birth, or they had little interest or little pleasure in doing things that they usually enjoyed. We also found that screening for depression was more common during the postpartum checkup than during prenatal care visits or healthcare visits in the year before pregnancy. So around 85% of women who went for a postpartum checkup were asked if they were feeling down or depressed during the visit, compared to around 78% of women who went for a prenatal care visit, and then less than half of women who went for a healthcare visit in the year before pregnancy were asked if they were feeling down or depressed during that visit. So next we're looking at the postpartum checkup specifically, and around 9 in 10 women with a recent live birth went for a postpartum checkup. And among those who went, around 87% had discussed birth control with a healthcare worker. 51% discussed healthy eating, exercise, and losing any weight gain during the pregnancy. And then around 55% were asked if they currently smoke cigarettes. And finally, looking at family planning. So just before getting pregnant, around 23% of Kansas women with a recent live birth had not intended to become pregnant. And in the months after the birth, around 31% of women were using a most effective contraceptive method. And I haven't shown this by like race and ethnicity or age or anything like that, but of course we do see some disparities in Kansas by a lot of these measures. So that will be something that we continue to explore over time and inform our partners about in Kansas. Next slide, please. So there are several strengths of the PRAMS data. As I mentioned before, the data are weighted to be representative of Kansas women with a recent in-state birth. PRAMS can be used to assess risk and protective factors among specific subpopulations like race and ethnicity, by age, or by socioeconomic status, or by urban and rural status. And alongside the birth certificate, the PRAMS survey provides a much more complete picture of health and experiences around the time of the pregnancy. So since we sample women from the birth certificate file, we have all of the variables from the birth certificate. We also have all of the variables from the PRAMS questionnaire side by side. So we just have so much more data about these births than we would have without PRAMS. And the many topics in the PRAMS questionnaire are not collected by any other statewide data source, or at least by any data source focusing specifically on the maternal and infant population. Of course, there are limitations of PRAMS data. So since it's a survey, there is potential for information bias, such as recall bias or social desirability bias. We also tend to have lower response rates among some demographics, like Black women, Hispanic women, younger women, and women of lower socioeconomic status. And unfortunately, the way that PRAMS was designed by the CDC, it was designed to look at estimates at the statewide level and not necessarily at the region or county level. But as we continue to collect PRAMS data, we will evaluate the ability to provide regional estimates. So if you'd like to learn more about PRAMS and see a lot more in-depth data than what I've shared here, you can visit our website. That's kdheks.gov/PRAMS. You can view our 2018 report, and we also have some fact sheets and presentations and other things on our webpage. And I've listed the contact information for our PRAMS team and for myself at the bottom of the screen if you have any more questions that you'd like to ask, especially about data that we can share.
So that's largely the quick overview of everything that we've got. There's the obligatory grandkids photo. They are also troublemakers who sometimes don't want to have their photo taken. So I use this for Facebook posting. Keeps them happy. So any questions people have, I'd be happy to answer, and Brandy can answer on PRAMS.
Greg, I'm going to jump in real quick, and first of all, tell you all thank you. The limitations of an hour, which I would actually say are at this point closer to 40 minutes. I really wanted you all to do exactly what you did. Give us the exhaustive list of what we currently have for data collection, make obvious the gaps, and help us to understand kind of where we hone in on some gaps of service, gaps of reception, gaps of data. And I think what I'm seeing in the chat is this exact conversation. So when we talk about what's available and what we need next, an example would be on the birth certificate, Greg. You mentioned the maternal morbidity pieces that are there and what's not there. I would say postpartum hemorrhage, for all of you on the call, is something that we all know needs our critical attention. If we dive deeper into why it happens to women of color at a significantly higher rate, again, those things are not carried through on something like a birth certificate, but would perhaps be on a hospital identifier for billing. Greg, can you talk about if this group decides we want postpartum hemorrhage to be our call to action, which it is, what do we do at the local level? Is it just making sure we document correctly at this point to capture the data? Do we have, what are the things that we could do at the local level to help be more accurate?
I would say that is the documentation part is going to be critical. Unfortunately, with the birth certificate, until we get another revision of the certificate, it may be hard to get anything added to the birth certificate. However, and I would say, and this is something, I guess, if it sounds like, postpartum hemorrhage, and again, how soon after the delivery are we thinking? And this is, within the time frame the woman would be at the hospital, or later than that even?
I would say both options. Okay. Both options would be true.
All right. So in that instance, then, if it's, I guess first I would say we probably need to look at what are we seeing in the inpatient side of the hospital visits for women who have delivered babies, and see that how much of that is documented. And I'm always impressed by the people that do all the coding, because they just seem to have a code for everything, and some events have 60 plus diagnosis codes, and they've made sure that everything is in there. And so I think that would be a good way for us to kind of get an idea of what the universe is. And then the emergency department data, when those situations occur, that we could look at both the long-term aspects as we look at ED data from the Kansas Hospital Association, and kind of see what it looks like for the big picture. And then once that's identified, a process could be established where, if we see a larger count at a particular hospital, we could work with that hospital and health department. And again, I'm going to apologize because I really don't know, what are the appropriate preventive steps that one might want to implement within a community. But certainly the ED data would be ways to monitor it in near real time. So if there's something going on, again, part of that would be in the initial analysis of that as a major issue, would be to look at when it occurs, whether there's any seasonality to it. And again, I'm just kind of guessing here. There probably wouldn't be something that's seasonal to it, but that would be in that hospital data analysis. And then, utilizing syndromic surveillance when that time comes for that. Now, I see the pregnancy-related mental health issues as something where we could see very quickly and easily an impact of on the emergency department visits. We've seen that with spikes on suicide attempts and ideation with juveniles and that sort of thing, where certain events that have occurred, nationally and sometimes even at a state level produce a smaller spike of ideation or attempts. And so that's where that routine monitoring can be beneficial.
Greg, there's some questions in the chat about making sure we include out-of-hospital birth, which I will tell you all is certainly a priority as well. Breaking it down regarding social determinants, certainly race, certainly county. And I'm just going to say on behalf of your group, the answer is quite easy and yet quite complicated. And the easy answer is that Greg's team, as you can tell today, is readily available. And I say that knowing that, again, it takes a while to work the data. But I wanted you all to see their faces and to know where their focus is so that you can ask specific county level data. But my charge and the charge of our committee is to make sure that this group knows what the state level data says, what our hone in and focus is, and certainly where we're going next. So know that is our charge for sure. And Greg, would you just echo that you all are more than available? I want you to say it out loud.
Okay, we are, and actually in talking to Ann a little bit, it's always interesting to have a group that some it's brand new exposure to it, others it may be they've heard of the data before. It's always something from a larger quality improvement perspective that I'm interested in and saying, okay, here's what we've got. What can we be doing differently? What could we maybe collaborate on? Things that we can produce that it may take some time sometimes, but certainly areas that we can perhaps get into. I know we can't collect everything, but we might be able to address, and there are other products that we've not covered here that might provide some additional background. I mean, we do a fairly comprehensive report at either a geographic level or at a hospital level of the birth certificate data. And I get requests a couple times a year from the birthing center director at some hospitals that say, can you give us this report where we want to be able to see our data that we submitted on all the births that we've had, and we produce that on request. And so it's just a host of things that we can do, some very easy.
And I'll let you go ahead. I know we're closing here for a few minutes. Do we have questions?
So I will pull the poll back up so that we can do our after poll. I'll just ask Greg, there are some questions that have gone by in the chat that we haven't had time to address. Would it be all right if I sent those to you and we can send the responses out to the group?
Sure, yes.
They're really specific questions about, for example, when is the birth certificate data set to go into revision, and how to weigh in on that process and so forth. So I will make a list of the questions that we haven't had time to get to and send them along to you if you don't mind.
Great. Be happy to respond.
Thank you so much. Okay. Well, I am going to attempt to bring this poll back up. And sorry, everybody, I'm a little bit unfamiliar. Oh, continue. Do you want to continue? Make a note here. Let's try this. Okay, I am relaunching the poll. Can you see it now? You should be able to see that I'm asking you the same questions. Do you feel like you have, you know where to access the county-specific maternal health outcome data for your county? I have about 50% of you have participated, 70% of you have participated, 75% have participated. And I'm sharing those results with you now. So thank you everybody for taking part in that poll so that we can evaluate how we're doing with these learning forums. I appreciate it. I am going to share this. Here we are. You should be able to see my screen now. I'm sharing with you some upcoming dates. Our next learning forum is on January 26th at noon. And the topic that day is going to be creating a postpartum care team. And then I'm also letting you know that we have the Kansas Maternal Mortality Review Committee has a survey that they'd like all of you to participate in, and the deadline for participating in that survey is January 29th. And then the next learning forum after that is February 23rd. So if you will bear with me for just a moment, I'm going to drop the registration link for the January 26th learning forum in the chat right now so that you can go right to it and register for it now if you can. And here it comes. Please pardon my struggles with this new technology. Haha, here we go. And there you are. There's the link that you can use to register for January. And so with that, on behalf of the Perinatal Quality Collaborative, I'd like to thank Greg Crawford and Gabe Haas and Brandy Markert for agreeing to present to you today. And thank you for your time and your interest. And we look forward to talking again next month.